I think the most common reason for a failed induction is for, dare I say, bad technique with inductions. Um, Now, otherwise, I would not call it a failed induction. So say, you've got to 10 centimeters and you've been pushing for however long, and there's like a malpresentation or compound presentation, blah, blah. I wouldn't call that a failed induction. You did it. Like your body did it. If something else happens later on down the road in the second stage, I wouldn't necessarily blame that on the induction. But if your provider tells you that you haven't been changing or dilating and like now you need a C-section when you haven't even had the chance to go into labor, that's a failed induction.
Hello and welcome back to another episode of the Birth Lounge podcast. Guys, it is finally here, our Black Friday sale. This is only one of 2 sales that we run every single year, and it's finally here. I'm so excited to share it with you. You can now get $150 off of your lifetime membership to the Birth Lounge. We run sales at Black Friday and Mother's Day, and that is it. Until the 28th, you will be able to save mega time on your lifetime membership of the Birth Lounge. Let me give you a little rundown about what makes the Birth Lounge so special. It is literally unhinged. It is like nothing else you're gonna find out there on the market, and that is the way that we are able to have the results that we have. We have people that literally walk away with absolutely zero birth trauma, and they achieve all of their birth goals, and they have no tearing. They push for less than 30 minutes, and the best one yet is that we have just a 3% C-section rate. Yeah, I am able to help you truly go into the hospital system, navigate the conversations with your provider, stay in control from start to finish, and avoid unwanted interventions and unnecessary things like an unnecessary C-section or an unnecessary induction. So how can this be? Well, I'm teaching you the control method, which is going to help you understand all of the aspects of labor that are within your control, and then we're going to teach you how do you control them. The problem that I find with a lot of traditional childbirth ed classes is that they just teach you your options. They say, well, you can have this or you can have that, and these are what your options are. But then when you get in the hospital system, you find that you're getting pushback from staff, or you're feeling like you don't really have those options, or maybe you're feeling pressured and you don't know how to navigate those conversations. That's exactly what I teach you how to do. I'm deconstructing all of those barriers, those road bumps, those things that hold you up from actually achieving your goals, because just knowing your options is not enough. The Birth Lounge is a comprehensive course. So when you go with the Birth Lounge, you will not need any other form of preparation when it comes to preparing for your birth. Inside the Birth Lounge, you are going to learn stages of labor, the ins and outs of navigating the hospital system, how to engage in respectful collaborative conversation with your medical team, pain relief options, labor positions, pushing positions, how to reduce tearing, how do you avoid things like induction, C-section, and unnecessary interventions? And finally, how do you advocate for your goals so that you can say yes to the things that matter to you? You can request alternatives when that's appropriate, and you can decline things that don't feel good to you. Plus, in the lifetime membership, you're going to get free access to our Dad Days course, which is a comprehensive course made for male partners to help them understand how can they best support you in pregnancy? What is their role in labor and delivery? How do they advocate for you? How how can they keep you comfortable and provide pain relief during the birth experience? And then finally, what is their role in postpartum and how do they help you navigate this new space of becoming a mom in the best way possible? You're also going to get access for free for our secret sauce to pushing. This is where I teach you how to achieve those results I talked about in the beginning. Pushing for less than 30 minutes, avoiding tearing, and really understanding what muscles to engage to properly push your baby out. First of all, your pelvic floor does not push your baby out. That lady needs to yield out of the way. So what muscles do you use? That's exactly what I'm teaching you in the secret sauce to pushing. And yes, I'm teaching you how to push with an epidural and without an epidural. Don't worry, I don't really care how you birth your baby. I want you to be equipped no matter what pops up in your labor, because this is your birth. I want you to choose how you want to do it. My job is to make sure that no matter what choice you make, you feel empowered in doing that. You're also going to get one of my number one downloads, which is our scripts for advocacy. This is an entire packet of the most common conversations that you're going to face in labor and in the end of pregnancy that often start you down this slippery slope of handing over your control. Not only do I provide you with the evidence to have these conversations, but I'm actually giving you the words to have these conversations, i.e. the scripts for advocacy. In addition to that, you're going to get all of my PDF guides, partner guides, epidural guides, induction cheat sheets, and my brand new Birthing Your Big Ass Baby course, where I step you through the actual data of truly evaluating whether your baby is going to be quote unquote big or not. What does ACOG say? What does the AAP say? And what are the true medical recommendations when it comes to suspected macrosomia, i.e. a big baby? I think you might be surprised to learn that less than 1% of all babies in the US are born truly meeting the criteria for macrosomia. So why are inductions and C-sections so common? Well, that's exactly what I'm teaching you in the Birthing Your Big Ass Baby course, and I'm going to teach you how you can decline those if they don't feel aligned to you. And finally, probably my favorite perk of the lifetime membership is you get a box that is handpicked by me, curated to help you have your best birth possible. This is a birth box that includes all of my favorite things, not only that I have used for the last 10 years to help women achieve their best births, but the same tools that I'm using in my own birth. Things like a TENS unit, a rebozo, a comb for pain relief, self-care items, breastfeeding items, and so much more. One of my favorite things is actually the fuzzy socks. I love them. They're so soft. Oh my gosh. This box is packed with goodies. It's worth over $120, and I'm sending it to you because I want you to be equipped to have the absolute most glorious and joyous birth experience that you possibly can. And I know that you can't do that without having the proper tools. And so not only do I teach you how to use those in the birth lounge, but I'm gifting them to you because I want them to be part of your birth bag. So through the 28th, you will be able to take advantage of our lifetime membership and $150 off. You can visit thebirthlounge.com/join to take advantage of this special Black Friday deal. Again, using code BF25 at thebirthlounge.com/join. Again, that code is BF25, 5 days only, thebirthlounge.com/join. Do not miss out on this. If you miss this sale, you'll have to wait till Mother's Day. I genuinely cannot wait to help you have your best birth possible. I'll see you in the lounge. Bye. Guys, today's episode is a Reair. One of the things that we did while I was preparing for mat leave is we looked at two things: our most popular podcast episodes and our most requested podcast episodes. And so then we took those episodes and we decided to re-air them while I am on maternity leave to help you continue to get the best, most up-to-date, and most requested information and education while I am away. So today's episode is a re-air. You will be able to find today's guest bio in the show notes along with any of the links, and we will note what episode number the original episode was in the show notes as well. So I hope that you enjoy today's re-air, and please know that you guys are absolutely on my mind. I'm hanging out over on Instagram, so head over there and say hi. Otherwise, enjoy today's episode.
Good morning. Well, at least it's morning here in Boston. I don't know when or where you're listening, but good morning, good day, good afternoon, good evening. Welcome back to another podcast, another episode of the podcast, the Birth Lounge Podcast. Happy Tuesday, you guys. Oof. 2020. Yikes. I was about to say this week has been hard, but then I think, wow, this month has been hard. And then I think, ooh, these last 6 months have been hard. And then I think, ooh, this whole year except January and February were really, really hard. And you know what? Even the beginning of the year, I actually started off 2020, January 4th, with a death in our family. Yikes. This whole year has just been incredibly crazy. Am I right? Just crazy. Well, I wanted to bring a little bit of normalcy back to you, but I don't think I did that in this episode because we're going to be talking about one of the things that I think nobody knows about. And this is a failed induction. Did you know that you could actually go to the hospital for a scheduled induction and it fail and you be sent home with no baby and also not in labor? It's true, it happens. Not often. And I would say, the more educated you are on your choices, probably the less likely you have to be manipulated into an unnecessary C-section. You at least will know that a failed induction is a thing and that you are allowed to go home. In this episode, we're also going to talk about your typical induction methods and what you need to know about each of those. I'm going to be sharing my ideas on your individual induction equation. If you don't follow me on Instagram, head over to Instagram and find me at Tranquility by HeHe. And you can find us at the Birth Lounge at the.birth.lounge. And I talk about failed inductions, induction methods, the different ways that you can be induced, plus what those mean for your birth later down the road, how you can stack different induction methods and the ones that don't stack, right? All right, I'm going to stop rambling because this episode is so good. So let me please introduce you to one of my friends, Becca Helie. And I'm looking at her intro here, and it is Rebecca. I don't call her Rebecca, and I assume that none of you will either once you connect with her on Instagram. She's not a Rebecca. She's totally a Becca. She's down to earth. She's cool. She's just the girl next door, and she's also a badass midwife. I connected with her on Instagram, obviously, where I find all of my friends, and Becca instantly was this warm soul. She also has this really dig deep of diva side to her, which, that spoke straight to my big old diva heart. Becca is one of the most golden, genuine people you'll ever meet, and so I'm thrilled to have her on the show today. She's an expert in all things prenatal care, labor, birth, and women's health throughout the lifespan. Sounds like exactly what I did in my master's, although, the whole lifespan wasn't really my jam. Earned her bachelor's in nursing from Brigham Young University in Idaho and worked for several years as an L&D nurse before earning her master's in nursing from the University of Cincinnati. Becca is certified by the American Midwifery Certification Board, is a member of the American College of Nurse Midwives, and is an educational affiliate of ACOG. Her favorite parts about women health are, just get ready, right? Shared decision making, ding. Empowering women, ding. Patient education, ding. And mentoring students. Now, that last one isn't something that I do, but I do mentor new doulas, so I'm sure that you can see exactly why I'm so excited to have Becca on the show today. P.S. If you follow along with her Instagram, you're going to get to know her little girl Jane, her husband Todd, and their precious little dog. Please head over to Instagram and give her a follow. At the end of the episode, we'll give you all the information that you can use to connect with Becca. So without further ado, Becca, welcome to the show.
Yay! Thanks so much for having me. I'm so excited to be here.
I'm so excited to have you here too. And for our listeners, Becca and I just chatted for legitimately an entire hour before this podcast got started, just chatting about birth and all the things we've been seeing lately. I'm really, really, really excited for you guys to join us in this conversation today. First of all, Becca and I share in a lot of the same sentiments. I think that we think very similarly in the ways that we approach birth, and the ways that we approach consent and patient choice, and the ways that we approach, support for both medicated and unmedicated labors, but also in support of people just being in control of their own stories. And for me, that was one of the biggest reasons that I connected with Becca, and on Instagram is how we first originally met. And it has been such an instant connection because everything she says, it speaks directly to my heart. And I hope that at the end of this conversation, you will take away the same things from Becca. And you guys can find her on Instagram at the end. We're going to tell you all the places you can connect with her. But today, Becca and I are going to be talking about inductions. And this is a sticky-ish topic, and I think people have strong feelings. And, I can't lie. I typically don't have great feelings about inductions. And for me, being Becca's friend and watching her on Instagram, I have learned so much. And I think she brings a very good perspective that is a healthy balance to my sometimes very strong anti-induction feelings. And so that's what this conversation is going to be about. So, Becca, opening thoughts on inductions from you.
Yeah. So I agree. I think there is a lot of fear and maybe a bad taste about inductions out there. And my whole purpose in my practice and on my Instagram is educating. And I don't want people to fear birth, and I don't want people to fear certain interventions in birth. So in my practice, like HeHe said, we both really connect on shared decision making, patient choice, education. So if my patients choose to be induced, then I educate them on what an induction is like, the risks, the benefits, and how that would go, because I don't want them to be fearful. So if there was a medical indication for induction, I don't want them to be so scared of induction that it impedes their labor or impedes their labor progress, or puts any unnecessary anxiety into their life that we're all already experiencing.
Or on their baby, right? So inductions are already kind of stressful because a lot of times we feel out of control. But I do want to touch on the fact that you serve a population that actually uses inductions as a means to control things and to actually have better births that they feel really supported about. But I think induction a lot of times actually makes people feel out of control because this is a place they never wanted their birth to get to. And so inductions have this way of already stressing out the birthing parent and baby. Can you tell us about how we can use inductions as a way to control things and actually put the control back into the birthing people's hands?
That's a good question. I think, one, and this really isn't a reason to be induced technically, but one of the great draws to induction is scheduling. And I mean, it just kind of cringy even saying that because no one wants their birth necessarily to be scheduled, but it can be beneficial in certain populations. Like I was explaining to HeHe before this, like I chose to be induced with my birth, and that made me feel less anxiety and more control because I was in midwifery school. I was doing clinicals. I knew I needed that fourth trimester with my daughter, even just a couple weeks to heal, because you know there's more to think about than just the birth, right? It's we so often focus on the actual delivery, and then we kind of neglect the mother afterwards in that fourth trimester. And so there's a lot that goes into it. The number one reason really for induction is going to be those medical indications, whether it be uncontrolled gestational hypertension, preeclampsia, intrauterine growth restriction, or any other indication that your provider recommends that you be induced. However, like I said before, what's critical is that you know how the induction goes, because there's a right and a less right way to be induced. It's important that your body is ready. And if your body isn't ready, you know, even so, let's say if you are having an elective induction, medical inductions, let's just not talk about those at this time because there's a lot that could go into this. But for an elective induction, you know, say that the method that you're being induced with isn't working for you, back up. Just back it up.
Yeah, I mean, I think you touch on a good point that everyone is going to have their own, I call it your induction equation. Everyone's going to have their own equation on how they need to be induced, and there are so many
Exactly.
studies about all sorts of different ways to be induced, and I think finding whatever equation works for you is just so crucial. And you're so right about the birthing parents' mental health. Your choice to be induced is all you need as a reason, right? If you have reached the point in your labor where or in your pregnancy where you are like, look, keeping this baby on the inside and not getting this labor started is going to be more harmful to me mental health wise than if I just go ahead and have an induction. It is right for you to get an induction. Okay, so let's talk about this. How do we be induced? You talked about right and a little less right about our equation. How do we put together this equation? What is the right and a little less right way to be induced?
So have you talked about the Bishop score on here before?
I have. So there is
So
a
yeah, refer back to that.
Yep.
Educate yourself on the Bishop score. So basically, in short, the Bishop score is kind of a measurement on how ready, so to speak, your cervix is to open up and dilate, or how willing it will be to respond to an induction. Now, I choose to treat patients, not numbers. And so simply looking at the Bishop score isn't going to give me the information I need. It's discussing with the patient her birth preferences. It's doing that cervical exam, of course, and then talking about the different ways. And now it's my preference to always err on the side of cervical ripening. So in order of getting the body ready for an induction, if your cervix is like tight closed, thick, no sign of labor anywhere, if we were just to hook you up to an IV and start that Pitocin, your cervix may not budge, for 24 hours. You may end up a C-section, or your induction may go just fine. However, evidence shows that if we encourage that cervix to soften up, to dilate just a little bit more, maybe efface a little more, and then we start the induction with Pitocin and get your labor going that way, there is a significant decrease in your risk for C-section or other complications of labor. So if my patients are like less than 3 centimeters, or if they're not very effaced, I am 10 out of 10 going to recommend cervical ripening. And there's basically 2 methods that you can go about cervical ripening. One is going to be medical choice, which is going to be a medication, and then the other is mechanical, and that is going to be a physical softening of the cervix. Now, as far as medical techniques for cervical ripening, I'll just talk about the two medications that we typically use. And they're both prostaglandins. And prostaglandins are those natural substances that your body makes that kind of trigger cervical ripening, trigger you going into labor. Now, the first one is going to be a pill. You can either put it in your cheek, you can swallow it, or it can be placed vaginally. It's called misoprostol. It's also known as Cytotec. Now, that one's great because it does stimulate the uterine contractions, that myometrial activity, along with the prostaglandins going ahead and softening that cervix. So it can go ahead and throw you into spontaneous labor. The second option is going to be a prostaglandin insert, and that's going to be like a Cervidil, and that is placed vaginally up by the cervix to soften up the cervix that way. Now, pros and cons of each of those medical management options. The pros, that you do get that myometrial contraction activity in addition to the cervical softening. Cons are, with the pill, once you take it, there's no going back. And so if you were to have any type of fetal heart rate distress, or if you were to have tachysystole, which is where you contract too much too often, then you have to go ahead and get another medication to stop the contractions. And so then we're just backtracking. And with the Cervidil vaginal insert, that can be removed. But however, again, to stop the instant effects, you remove it, but then you have to give terbutaline or something to stop those contractions. And so there's definitely pros and cons to going the medical way of cervical ripening. Me personally, it depends on the patient, and each case is just so different. And I think really all providers should be looking at their patient as an individual. For me to say that I give every person Cervidil would be just ridiculous. Or for me to say I do mechanical methods on every single patient. Contraindications to these prostaglandin medical cervical ripening agents is for our TOLAC or VBAC patients. If you do have any history of prior uterine surgery, it's not recommended because there is that risk for contracting too much, too often, putting unnecessary stress on that uterus. And so that leads us into the second option for cervical ripening, which is your mechanical methods. And then again, there's two options. You're going to have something called the Cook catheter and then something called the Foley catheter. Now, the Foley involves one cervical ripening balloon, and it's a thin, flexible tube. They'll place it like if you've ever had a pap smear, they'll use a speculum just like that to visualize the cervix, and then they'll insert the catheter through the cervix, right up next to the baby's head inside the uterus, and then they'll inflate that balloon full of like saline or sterile water and just leave it there. And it puts pressure on the cervix and also releases some prostaglandins just by the fact that it's irritating the uterus. It's in that space between the amniotic sac and the uterine wall. And so for some people, even just having that balloon in place will trigger labor. And the purpose of that is, again, to put pressure onto that cervix and hopefully soften it up and get it to dilate. With that Foley balloon, which is the single balloon catheter, we allow our patients to go home with that. So we'll place it in office. We'll be like, let that work overnight, see you in the morning for the rest of your induction. And that's a really great option because it decreases costs from being in the hospital, and it's more comfortable because you can continue to labor at home. And hey, if you do happen to go into labor just from the placement of the Foley balloon, you can labor at home. And so it's kind of a great starting option for people who are still hoping to go into spontaneous labor. The second is going to be that double balloon catheter. And for this, we do have people stay overnight in the hospital for monitoring with this. And one balloon will be placed inside the uterus, just like with the Foley balloon. And then another balloon will be placed vaginally. It's all part of this same catheter, but these two balloons kind of act like a sandwich to smush that cervix, soften it up, get it to dilate. And so they have a similar mechanism of action, but work a little bit differently. Typically with the Cook catheter, which is going to be that double balloon catheter, it's inflated a lot more. And so it can be pretty uncomfortable. I mean, imagine having an 80 mil balloon in your vagina. Like that just doesn't feel good. However, the benefit is so much more than risking, is my cervix going to soften and dilate with only the addition of Pitocin.
So why does someone need to stay in the hospital and be admitted with a Cook balloon, that double balloon, versus the Foley, the single balloon?
The single balloon, we only inflate like 30 to 50 mils. It's just a small amount of fluid. It's only in the uterus. Babies tolerate it fine. Moms usually tolerate it fine. With the Cook catheter, we inflate it 60 to 80 mils on either side. It's a significant more amount of pressure on that cervix. We usually don't see a lot of fetal heart rate problems with the Cook catheter, but if we were to, we're in an environment that we can manage that or even monitor it. I just typically don't do continuous monitoring with my Cook catheters. It's just not necessary unless you start going into labor. And it's much more common because of the larger size of the balloons with the Cook to get thrown into labor, and for things to go on. And if the Cook catheter falls out, usually patients are at least 6 centimeters just for the diameter of that 80 mil balloon to slip out of the cervix. They're going to be at least around 6 centimeters. And at that point, they're needing some type of pain coping and things like that. So honestly, monitoring, pain relief are the two main things.
That is amazing. I love so much how we just went through all of these options to make exactly your induction equation, right? You have all these options, and I think you did a very beautiful job of laying out that it truly depends on what your body is doing at this time in this pregnancy / labor. Like even second and third time parents, your body's going to be different at this point than it was in your previous labors, right? Okay, I love that so much. Going back a little bit to TOLEC and VBAC, those parents need to start with mechanical versus medical induction. Is that correct?
Yeah. So versus the medication or mechanical, VBAC is going to be a contraindication to those prostaglandins because, like I said, once they're in, they're not out. And you are decreasing your chance of having a successful VBAC if you're starting out your labor with a ineffective or too frequent, too strong contraction pattern. You're going to run into issues like fetal heart rate issues. You're going to run into issues where that uterus just isn't tolerating the labor. Because with a TOLAC and a VBAC, I am 100,000% a supporter of VBACs, but I also understand that there are risks in having a vaginal birth after a C-section. And so knowing those risks, I want to be able to give you that individualized attention to your uterus. We're babying that uterus when you're in labor as a VBAC. And so giving you something like a prostaglandin that we can't really take back is not a smart choice.
So let's talk about inductions for a VBAC, because we actually support quite a number of VBACs. And, you know, sometimes we reach the point where we do have to induce, but we are really still hanging on to our birth goals of having a vaginal delivery. What can this look like? We are going to start with a balloon or catheter of some sort. And then is Pitocin appropriate? Can we talk about the risk of Pitocin in VBACs?
Now, you may be thinking, you just said that we don't want to give medication to VBAC because we're babying that uterus. However, Pitocin works differently than prostaglandins. It is still a medication, right? And we're still making that uterus do something. However, we can adjust the Pitocin so minutely to get you that perfect dose for your body. There's different protocols for increasing Pitocin. However, in my hospital, we increase it 1 to 2 milliliters per hour. So that's like 1 to 2 drops per hour of Pitocin that you're getting up until you're in an adequate contraction pattern based on the frequency of your contractions, the strength of your contractions, and then how baby's tolerating that. Now, ACOG says that you can absolutely use Pitocin on a VBAC, and I think a lot of providers are afraid of inducing a VBAC, or there's so many providers who don't even accept VBAC patients. And sure, they absolutely have a right to be concerned and be careful about that, but I don't think that there is reason to be fearful. And that's like my whole purpose, is taking away that fear from people. So if I had a patient who was wanting a trial of labor after C-section, and she was, like I said, less than 3 centimeters, not very effaced, I would recommend that she get a mechanical cervical ripening. Because she's a VBAC, I would want her on continuous monitoring. So I would put her, I would probably recommend this Cook catheter for her. And then that gives her cervix a chance to soften up, to dilate, efface a little more. Maybe that catheter falls out and she's ready for labor support, or maybe after 12 hours we end up removing the catheter, but her cervix is now like 80% thinned out and she's 4 centimeters, so she's at a really great starting point. Then we can add that Pitocin on to help her to contract at an interval that we want, but we can also back off on the Pitocin or add more fluids. And so it's a lot easier to manipulate Pitocin than it is with other oral medications. If that makes any sense.
That makes total sense. Have you heard about the baby soap debacle that happens in the L&D rooms across the US? Well, if you haven't, then let me let you in on a secret. The hospital system often will use something like Johnson & Johnson's baby soap as lubricant in labor. So remember when we were all little girls and we were told not to put soap in our vaginas because it can throw off the pH? And even now as adult women, we're told that we don't need to wash our downstairs lady because she is self-cleaning. She can do it herself. But then in labor, they're going to put Johnson & Johnson's of all soaps in your vagina to what? Help your baby be more slippery, which they don't even need. But I understand if you might want a little extra lubrication down there during the pushing period, and I have a much better option for you. CocoNu. And if you haven't heard of CocoNu, it is one of my favorite lubes. CocoNu's products are made with all organic coconut oil, organic coconut water, and other natural ingredients like organic beeswax, organic cocoa butter, organic sunflower oil, and organic shea butter. Because you know what? What you put in and on your body, specifically for your vagina, the details matter. I love that CocoNu uses plant-based, non-GMO ingredients, which are also USDA certified organic whenever possible, and their packaging is plastic free and it's made in the US. CocoNu offers oil-based and water-based, because if you use toys in the bedroom, you shouldn't be using oil-based lubes with those, only water-based. So they wanted to give you both options, but I gotta be honest, my very favorite product that they offer are the singles. These are single packets that you can literally order a box of, put them in your birth bag, and then if you need extra lubrication during labor, you take the box out, use the single packets. You can use one, you can use all of them that come in the box, and I just love it. I think it is such a better option for you to not only give you that extra lubrication if you want it, but you don't actually need it during labor. It helps you have healthier, better sex during pregnancy, because obviously we want to make sure that everything you put in and on your body in pregnancy is organic and safe for you and your baby. And it's much better than Johnson & Johnson baby soap, which is going to disrupt the pH of your vagina. Which, who wants a yeast infection in postpartum? Yuck, not me. What an actual nightmare that would be. So head to coconu.com, that's COCONU.com, and use code HeHe to save 15%. coconu.com, use code HeHe, HeHe, to save 15% and protect the pH of your downstairs kitty. Meow. I also want to touch on the study that we were chatting about before that shares about inductions using Pitocin and break-in waters early on. And that definition is 4 centimeters or before, so 0 to 4 centimeters, but with the use of Pitocin as well for an induction.
Yeah. So in the birth world, and especially in the midwifery world, we're always thinking, how are we going to use evidence-based practice, and how are we going to give the best experience to the birthing person? Now, breaking water has a lot of, I will say, conflicting evidence out there based on my own clinical practice and based on what we're reading out there in the literature. It
I
says
support
that,
that. I would say the
yeah,
same.
yeah. So basically what the research says is that early amniotomy, which means breaking the water early, is associated with 3 to 5 hour shorter labors when you're inducing with Pitocin. Now, this is not talking about spontaneous labor. This is talking specifically about inductions. So when you're being induced, it is most beneficial to have your water broken if you're less than 4 centimeters and on Pitocin. So that allows the uterus to contract more effectively, dilate that cervix, get that head applied. And now, just because we were mentioning about VBACs, I will say that it is a very smart decision to break your water with a VBAC, because starting with that water ruptured, you're getting the most effective uterine contractions and the most effective pressure of the head on that cervix, in addition to the Pitocin, with the least amount of pressure on that uterine incision. If the water is not ruptured and you're contracting, that's fine. However, the pressure of that amniotic sac is also putting pressure on that uterine incision. And so from a safety standpoint, breaking the water is going to put the least amount of pressure on that uterine incision and give you a better chance of having a successful vaginal birth after C-section. So when I do, let's say, for example, I'm inducing a patient electively, she chose to do the cook catheter overnight after we talked about it. We removed it in the morning. So if we're starting Pitocin that morning, we'll start Pitocin, gently titrate up until she's in an effective contraction pattern. And I will break her water if she's less than 4 centimeters. And that will hopefully shorten the length of her labor, as the evidence shows. Now, if she was in spontaneous labor, I'm not just going to go break her water at 4 centimeters when she shows up to the hospital. So that's why I say it's so individualized, the patient care, when you're doing things. And that's why I want to get this information out there, because I think so many people are just like, think all inductions are bad, or all breaking water is bad, or, nothing in the birth world is black and white. There's so many gray areas. And that's why it's so important to have a doula to stand up for you, to have a provider who honors your wishes and who listens to what you care about, and who isn't afraid to tell you the good, bad, the ugly, and answer all your questions.
It's just honesty. It really is. It just comes down to providers that believe in consent and they understand patient choice and have the ability to separate, themselves and their experiences from that patient's choice, and really respect that. Even if as a provider, you're like, yikes, I would not choose that. It is really important, right? Okay, so I have 2 questions. What if, and I want you to answer on both a VBAC and then someone who's not a VBAC. What if, as we're titrating up that Pitocin and we're waiting for contractions to get into a regular pattern, we are right on the verge of 4 centimeters. Do we go ahead and break that water before we're in a regular pattern, or do we wait?
I would, and it depends. So kind of, and HeHe and I were talking about this prior to the podcast, but think of the mechanics of that cervical ripening balloon. Think of 80 milliliters of fluid. That's like what, like, I don't even know, a tennis ball, probably smaller, but a little smaller than a tennis ball, in between your cervix and your baby's head. That's a lot of space. So if I were to remove that cook catheter and then instantly check your cervix, break your water, that's a lot of space between your cervix, the amniotic fluid, and the baby's head for other things to come out, like maybe the baby's hand coming up by the head, which is going to make your labor longer, pushing harder. Maybe even the umbilical cord coming out, which is an obstetric emergency. And so what I will usually do with my patients is I will have the balloon removed by the nurses, and then they'll start the Pitocin to get that head down closer to the cervix to close that gap where the balloon was in between the cervix and the baby's head. So that when I come in and do my morning rounds, I check the cervix. I'm always ensuring that the fetal head is pressed tight against that cervix so that when we do rupture those membranes, nothing else is coming out. That gives the baby the best chance to go into the optimal position for birth. So even if she, maybe she comes out and the catheter comes out and she's 5 centimeters, I'd still break that water because this is a mechanical dilation, right? It's not that she has been in active labor and has contracted herself to 5 centimeters. She's only 5 centimeters because she's had a vice on her cervix for the last 12 hours, So another thing that I will warn you about is if you do have a mechanical cervical ripening like that, and you don't start going into active labor for another 6 to 12 hours, don't freak out. Like, you literally weren't in labor until we started that Pitocin. Just because you had the balloon and you're 5 centimeters doesn't mean that you've been in active labor to 5 centimeters and now you're having a prolonged or stalled labor. No, we have to gradually get that labor going. And so that's something to be aware of. Just because we start the Pitocin doesn't mean you're in active labor.
Totally. That makes so much sense. Okay. And I'm about to ask this question, and I know the answer to this question, but I just want to hear a professional and someone, who's actually in medicine, not just doula, say this and
Don't say just a doula.
I mean, I just want to hear you assure people that this is a real thing. Pitocin, can we turn it off? And can we turn it down? Because I always tell people you are in total control. If you feel like things are getting out of control, let's turn down that Pitocin. You can turn it off. We have had providers, both nurses and actual providers, tell clients we can't turn it down and we can't turn it off. Once we go up, we're just kind of there. And so I would love to hear your perspective, of the thought that, we're kind of hands off in birth and people actually lead their own births rather than providers.
Mm-hmm. I don't there's no safety or medical indication as to why you cannot decrease or turn off the Pitocin. Like, there's no reason. The only reasons why you would not want to turn off or decrease the Pitocin is if you don't want the labor to slow down. So maybe from a provider standpoint, they're like, no, we got to keep this Pitocin on and going. Like, you're here for induction, so you're going to be induced. We're not moving backwards here. So I could see them having that reasoning. However, a safety reason for not turning off or turning down the Pitocin, absolutely none. And oftentimes, so if you're being induced and you're kind of getting to that transition phase, you're in active labor, your body's going to probably get the hint at that point. So turning down or turning off the Pitocin around 7 centimeters when you're really struggling at that point, if you're going unmedicated, is really not going to hinder the progress of your labor that significantly. And hey, if your contractions do end up spacing out, so like every 10 minutes apart, then we go up a little, but at least you got that little break. I actually do that very often with my unmedicated patients who choose to be induced. We kind of get them to that transition, that active labor. Maybe we're in the shower or we're getting in the tub or we're doing things that IV is just getting really cumbersome. We take a break from the Pitocin. We labor in the tub, we labor in the shower, we do whatever we're doing. And oftentimes their body already knows what's happening. Like, they're 7 centimeters, there's no going back at that point. And their body will oftentimes take over. And then sometimes if it slows down, we can easily just put it back on. And that's the beauty of Pitocin, is that it can be so gently titrated up or down or changed. And that's why it is the method of choice in induction. This kind of, I don't even know if this is appropriate, but it's a funny story because I chose to, well, I say chose lightly. I chose to go unmedicated with my daughter Jane, and I also chose to be induced. And there was a point where I was like 8 centimeters, and my nurse on labor and delivery happened to be like one of my really good friends. And at that point, my Pitocin was at like 8 milliunits a minute. And so 8 milliliters an hour is what that would go out to be. So really not that crazy of a dose. But I was just like, I was so done. I was just like, Abby, turn that pit off right now. She's like, okay. And I was like, yeah, turn it off. And I was just like, I don't even care. turn that shit off. Like, I was just like, I'm not having one more of that. And then my body just, I was doing it. I didn't need any Pitocin for the, like, I knew I didn't need it at that point. And maybe you don't know that, but maybe your provider or your midwife or your doula is like, no, you're doing this, and we'll let you know if things space out. But there kind of gets to a point in labor where, at least that's how it was for me, where like I didn't need that. My body was doing it, and oftentimes it will. Now, if you have an epidural, maybe you won't have that feeling, and that's totally fine. And we can just the Pitocin is needed at that point as well.
I find the same thing. I mean, oh my gosh, I can't even tell you how many times we have, really had a discussion with providers and decided to either turn it down or turn it off. And same thing happens, right? We find that their bodies are doing it. And then generally, if we turn it off or turn it down, we're able to turn it completely off. Of course, it does kind of require you to be so far along in labor where your body does kind of,
in active labor.
Totally. And has gotten the message, like exactly what you said. We ain't going back now. Like, this baby's coming out. We're like in this, right? We're like really in
Totally.
this. Do it. Yeah. So I thought that was a good discussion. I think that, there's definitely a conversation to be had when we're talking about management of Pitocin use. And a lot of providers sometimes don't provide that space for clients to engage in that conversation and to ask these questions and to truly understand the difference between Pitocin, a synthetic drug, and oxytocin, which is natural, right? And your body, at the end of the day, the truth is your body does metabolize them very differently. They are going to have different effects inside your body. And so I think as a consumer, we have the right to understand that. So I'm going to have that discussion. Okay. Here is my number one question that I actually brought you on here to talk about, because this is what I learned from you. Let's talk about failed inductions. A, who has even heard about that? B, who even thought an induction could fail? And C, how do we manage a failed induction? What does that look like? How do we go forward? Does it mean we have to have a C-section? What's this look like?
So let's talk about this in the sense of elective inductions. Now, with a medical induction, there's a reason that your baby needs to be born on that day at that time. So sure, you can have a failed induction with a medical induction, but specifically speaking on elective inductions, you are more likely to have a failed induction if your body isn't ready, your baby isn't ready, your cervix isn't ready. Now, the best way that we can prepare that cervix is making sure that if you are a candidate for cervical ripening, that you get that done. I would never start Pitocin on a patient who is 1 centimeter in thick and hope for the best. I always choose cervical ripening for that reason. I don't care if it's your 5th baby. It's better safe than sorry, in my opinion, to give you the most successful birth outcome.
Same. I agree with that wholeheartedly.
And the times that you're going to run into failed inductions is if that cervix is not prepared. And, it is such an individualized. I look at their birth history, I look at their weight, I look at their birth plan, I look at their cervical consistency and dilation. I don't just say your Bishop's score is 7, let's not do cervical ripening. You have to look at the patient holistically to decide the best plan. So if you have cervical ripening, you're on the right way. Now, maybe you're 4 centimeters in office and you don't even need cervical ripening. That's fine. Then you're a better candidate to start with that Pitocin. So the times when we run into failed inductions are patient is 1 centimeter, they start Pitocin, they've had Pitocin for 24 hours. They say, well, you have to have a C-section. Well, actually, you don't. If your membranes are intact, which means your water isn't broken, you have no coexisting conditions or risk factors, you're otherwise healthy, and you don't have a fever and you're coping with your pain, maybe come back when your cervix is ready. So you've been in labor, not really labor, you've been on Pitocin for 24 hours and you're still 1 centimeter. Why are you there? Nothing's happening. You don't have to have a C-section. What's the point? Maybe you're being induced because, your doctor was afraid that your baby would be too big to fit through your pelvis, so you need to deliver early to keep that baby small. So you either have a C-section today, or you have a C-section next week when maybe you have a chance at laboring and dilating. And so think and talk with your provider, but know that it is absolutely an option to go home if your induction is not going to plan. Things that would prevent you from going home is signs of infection, or if your water has been broken. So if your water has been broken for that length of time, then that's really not going to put you in a good position. And now you may be thinking, Becca, you just said to break water early. I said that after cervical ripening, and I said that with your provider's best clinical judgment. And I also said, never would I ever start Pitocin on someone who A, did not have cervical ripening, or B, was not at optimal cervical dilation or effacement for adding that Pitocin. So I think the most common reason for a failed induction is for, dare I say, bad technique with inductions. Now, otherwise, I would not call it a failed induction. So say, you've got to 10 centimeters and you've been pushing for however long, and there's like a malpresentation or compound presentation, blah, blah. I wouldn't call that a failed induction. You did it. Like, your body did it. If something else happens later on down the road in the second stage, I wouldn't necessarily blame that on the induction. But if your provider tells you that you haven't been changing or dilating and like now you need a C-section when you haven't even had the chance to go into labor, that's a failed induction. And there's absolutely ways that can be avoided. Like I said, with a medical induction, however, we often don't have that kind of time to let you go home for a week or whatever. And so that's why medical conditions often lead to more intervention.
Totally. It's not as leisurely. I
Mm-hmm.
totally get that. So, as far as a failed induction, we're really defining that as if we try and get your labor going and we literally cannot, that is a failed induction, you guys. But if
Mm-hmm.
you start to go into labor, whether that is, Pitocin induced or the
Mm-hmm.
balloon sent you into labor, once you're in active labor, that is not a failed induction, you guys.
Yeah.
We're literally talking about your labor not getting started. So while we're on the topic of failure, I absolutely despise using the terms failure within birth.
I
But
know.
can we talk about failure to progress really quick and what that definition is so that we have a good, clear indication of, once our labor gets started? Also, I think there's a healthy recognition to talk about the places that we often see these breaks in labor for women or birthing people to take a break.
So there is technically going to be a stalled labor and an arrest of labor, or another word for stalled labor is a protraction of labor. So protracted of the active phase is going to be if you're greater than 6 centimeters and you're dilating less than 1 to 2 centimeters an hour. But if you're less than 6 centimeters and you're in the latent phase, it may take 6 to 7 hours to progress 1 centimeter. And like, that's totally normal, regardless of what baby it is for you. An arrest of labor, which is going to be, what did you call it?
Failure to progress.
Failure to progress, or an arrest of labor is going to be no cervical change for greater than 4 to 6 hours with adequate contractions. And the only way to measure adequate contractions is if you have an intrauterine pressure catheter. So you technically cannot diagnose an arrest of labor unless you can confidently say with an intrauterine pressure catheter that you have been having adequate intrauterine pressure for at least 4 to 6 hours, or absolutely no cervical change for 6 hours with inadequate. So sometimes we're like, geez, this girl hasn't changed for 8 hours. And then we end up doing the intervention of placing an intrauterine pressure catheter to see the exact pressure of the uterus. And heck, she's barely even contracting. Her contraction strength is nothing. So then we adjust the Pitocin. We're like, oh, well, no wonder you weren't changing. You were barely contracting. And so it takes a lot of assessment before just jumping to a diagnosis like that. So protracted labor is kind of where you're kind of going through a slow period. And that's normal. Like I said, it may take 6 or 7 hours to go from a 4 to a 5, 4 hours to go from a 5 to a 6, and that's normal. Arrest of labor is when you are an active phase arrest, is when you're greater than 6 centimeters. These are the things you have to have. You have to be greater than 6 centimeters. You have to have your water broken, and you have to have an intrauterine pressure catheter over 4 hours with absolutely no cervical change. Or you have to have greater than 6 centimeters, water broken, and absolutely no change in greater than 6 hours with inadequate contractions. So in my practice, I would never diagnose someone with an arrest of labor without measuring their uterine contractility. Like I need to know that her uterus is or isn't working. Because if her uterus is like doing her best job and like we're changing position, we're doing everything, we have to begin thinking maybe there's a reason like we're having this arrest of labor. Let's think of other causes rather than just going off of a simple 6 hours. Like the time is honestly negligible. We're thinking of the physiology. What's going on behind the scenes? We're in active labor. Is our uterus contracting? Is our baby in an optimal position? Is that bag of water broken? Does she have a fever? Is she fatigued? Does she need more calories? We're thinking of all of these other things. You can't diagnose an arrest of labor off of a simple time.
I was just at a home birth on actually Wednesday through Saturday. It was quite a long home birth. And you just named all the things that we kind of went throughout these days leading up to her midwives joining us. We kind of did this, and you're right, it took us forever. I mean, it took us days to get to 6 centimeters, and we were going through all of that. She was eating, she was drinking, we were moving, we were resting, we were in water, right? We were doing all the things, and she did. I mean, it ended up being a beautiful vaginal delivery, but it just goes to show that you're right. The time is negligible. And I think there's so much to be said about birthing in the hospital system in America that we oftentimes see people put on a time clock. And as a consumer, you really need to understand that time is on your side. Actually, if you know enough about the time of labor, you can actually use it to your advantage.
And here's another thing, because the latent phase of labor, which is when you're less than 6 centimeters, so less than 6 centimeter latent phase, greater than 6 centimeter active phase, you're less than 6 centimeters, we don't even quantify that time in any way. It is so freaking slow for some people. Some people, it's like feel like you're in labor for weeks. It's not a clinical entity, that time in labor. So you can't even diagnose an arrest of labor in the latent phase. So if you haven't changed from a 3 to a 4 for 7 hours, and they're saying that, you're having a failed labor or whatever they're calling it, arrest of labor, no, that's all I have to say is no. Because you're not even in active labor yet. So how could your labor be arrested if you're not really, like, I don't even know.
If things haven't actually gotten started in a rhythmic pattern, right? I think there's people just think that, okay, I'm having, 3 contractions an hour. This is it. This is go time. No, I mean, yes, maybe, but also high likelihood that things stop. High likelihood that, it's stop and go for a little bit as your uterus gets your baby in that final position, as your uterus practices, as your body gears up for real time go time. And I think a lot of people just have a misconception with that, and then it really throws them for labor, and then we have providers out there pressuring people on that time clock, and it just kind of recipe for disaster. So wow. All right, this has been such a fun conversation. Thank you so much for joining me. What else do you want people to know about inductions? They get a bad rap. Pitocin gets a bad rap, but neither one of those things are bad. They just need to be used with respect and caution and, evidence-based. They really need to make sure that we are making decisions based in research, not based in past experiences or fear or anything else.
Yeah. And I couldn't have said it better myself. That's exactly what basically the bottom line that I want to share with people is that every intervention has a time and a place. And when used, like you said, respectfully and with the birth plan in mind, they can be amazing tools. We have these tools, and when used appropriately, they can make for beautiful births. One of the most popular questions when I talk about inductions that people have is, I hear inductions make your labor worse, or I hear inductions make your labor longer, or I hear, like, there's so much hearsay about inductions, which I believe is where a lot of the fear comes in. So I want people to be asking their provider, ask their doula questions. Don't just take what stories you hear as evidence. Really have that conversation and make the choice for yourself. Now, labor hurts. If people tell you it doesn't hurt, I'm sorry, it hurts. You can cope with labor despite the pain. You can use tools to have a good birth experience despite those experiences. Does Pitocin make your labor worse? It doesn't have to. And I hope that if you choose an induction, you don't feel like you had a worse experience because that was your choice. I want you to have the tools to cope with your labor despite choosing to be induced. Now, with the way that the Pitocin works, we're gently titrating it up. Maybe every 30 minutes, we're increasing your dose to get you into that active labor pattern. Whereas with spontaneous labor, maybe your uterus is gradually ramping up over a week or two. And so it's going to feel a lot more natural, dare I say, to kind of go into this labor curve where, like, oh, I'm kind of getting more Braxton Hicks. Oh, now I'm getting kind of crampy. I'm having period cramps for the last couple of days. Man, now I'm having contractions, I think, every 30 minutes. Now they're every 20. And so you get this very gradual climb to active labor. However, with an induction, we are bumping that Pitocin up every 30 minutes until you are in active labor. So you go from 0 to 100 real quick. It's not that the pain is any different physiologically. It's just that the onset is faster. You have a shorter time to cope with the changes in your labor progress. You may have more difficulty changing positions. You may have more difficulty getting that labor support. You do need continuous monitoring when you're on Pitocin. And so there's a lot of other things that go along with it, but it's not necessarily the fact that you're being induced. It's the other challenges that you have to face being in the hospital and being induced. And so as long as you're prepared to face those challenges and you're educated about the things that you're going to do to cope with your labor, and you have a supportive birth team, whether that be your spouse, your labor nurse, and really communicating. Like, communication is key in all labor, but especially within induction. Let your provider know your wants and your wishes. Let your labor nurse, that person, your labor nurse, he or she is going to be with you for the whole ride. And so making sure that you guys are on the same page is going to be critical. And so I just wanted to kind of dispel that myth that, yeah, things go quicker, it may be more difficult, but it's not going to hurt any more or any less either way. You can do it. Like, you 1000% can do it either way. Whatever you choose, you're just going to face different challenges in either choice.
I love that so much. I mean, birth hurts, right? You said it, but birth is also messy. It is messy, and it's gonna be messy, and it has always been messy, and it always will be messy. It's part of why I love birth, right? Birth is so much fun, and it's always new, and there's no two births the same, but that is messy. It's messy for birthing people. It's messy for support people. It's messy for providers. Birth is just messy, but at the end of the day, you truly do get to be in control of your labor. And I think for me, that is all I want people to walk away with. I am the queen of saying, I don't care how your labor goes. And it's not to be mean, but it truly is. I could not care less how your labor goes. I just want you to walk away feeling supported and able to tell you nothing crushes my soul more than, and this like makes me want to cry right now. Nothing crushes my soul more than to know that somebody did not feel supported during their birth. Like, it truly, you can hear it just guts me. I just can't cope with it. Your birth is a place where you deserve the ultimate support and respect, and that you truly deserve to be in control. And that's all
I love that.
Everybody.
I couldn't have said it better myself. I feel the exact same way. And where was I going to go with that? I can't even remember, but I wanted to say, I don't want there to be any shame about whether or not you choose to be induced or not, whether or not you choose an an epidural or not. Like, no shame is welcome here. It's all about choice and informed consent, support, and knowing what you're getting into and dispelling that fear. And so I think that's why HeHe and I connect so well, because we do have a lot of those very same core values, even though we're in different parts of the country and we are in a little bit different role in the birthing room. We have the exact same core beliefs, which is informed consent and giving that birthing person the experience that they want and that they deserve.
Totally. And I think this is so beautiful that there are people all over the country and in different roles that we can come together and collaborate and educate people on their choices and exactly what kind of control you have in labor. So thank you so much for being here. Okay, we talked a lot about your Instagram. You talked about it. I talked about it. So much fun. Where can people connect with you, and where are you located? Tell us a little bit about how people can join your journey.
So I am a certified nurse midwife and I practice in a rural town in Idaho, and I run an Instagram account. It's just my name. It's at Becca Helie, CNM, which is my credential, and Becca_Helie_CNM. And my purpose with that account is I share a lot of personal stuff about my family and just being myself. It's kind of my own space, but I also like to answer questions, dispel myths, give reassurance, and just post general information about women's health on there. So love to have you come ask your questions.
You guys don't forget to go over and find Becca on Instagram. I legitimately get on Instagram sometimes just to see what is going on
It's so
her
sweet.
account. So head on over there. All right, guys. Thank you so much for hanging out with us today. Becca and I had a fantastic time chatting with you. I hope that you're walking away feeling a little bit more secure in the idea of an induction. I hope that you are feeling more informed on the options that you have when it comes to induction. And I hope that we helped dispel a few myths about induction and helped you feel more confident if your birth tends to need to go that way. All right, guys, happy Tuesday. I will see you again on Friday for another Friday free talk. Until then, take care.
Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.